Thank you very much, Dr. Akhtar, for this invitation on this very important heart failure symposium, where almost every aspect of heart failure is being discussed. And we have enlightened ourselves on the topic of heart failure. May I have my slides, please? Okay, so we have been hearing about the heart failure, how serious it is, and what are the things by which we can treat it. So I would be talking about the assessment of diastolic heart failure. Um, Unfortunately, all around Pakistan, if we look at the echo assessment of people, generally people would talk about systolic heart failure or systolic function of the biventricular systolic function is normal or impaired is a general report which we tend to see. People generally ignore the assessment of diastolic function, or if they are assessing, they are keeping themselves to just one or two parameters and not what is being done all around the world today. So I would try to do and try to update ourselves regarding this diagnosis of heart failure with preserved ejection fraction. So we have to understand that when we say diastolic dysfunction, simply these are abnormalities in the mechanical function during diastole, but this is not diastolic heart failure. When we say diastolic heart failure, this is a clinical syndrome, predominantly or isolated abnormality in diastolic function with symptoms and signs of increased tissue organ water and decreased tissue organ perfusion. So if we have these things along with the echo parameters, only then we say that this is heart failure with preserved ejection fraction. The universal definition of heart failure requires, in addition, at least one of the following: increased anti-pro-BNP or objective evidence of cardiogenic pulmonary or systemic congestion. So this is the 2023 ACC expert consensus decision pathway, which says that, as my previous friend like Dr. Shahbaz and others were saying, that more than 50% of cases of heart failure, this is heart failure with preserved ejection fraction, and the outcomes are comparable with HFrEF or reduced ejection fraction. So we need to know what are the lifetime risk of heart failure. For every 40 years or older, 1 in every 5, about 20% are going to get heart failure. And for women, this increases to about 30%. So this is a very, very important area which we should try to understand. The incidence of heart failure with reduced ejection fraction is declining, all thanks to our excellent medical armamentarium, like all the 4 pillars which Shahbaz Qureshi was talking. And the incidence of heart failure with preserved ejection fraction is rising because we don't have much to offer to these patients. Only SGLT2 inhibitors are now being favored as the standard kind of therapy. So we need to know, we know that this is a serious condition. We know that this has outcomes similar to heart failure with reduced ejection fraction, but we need to know how to diagnose that. And to diagnose HFpEF, we need to have symptoms and signs of heart failure. Ejection fraction should be equal or above 50, and then objective evidence of cardiac structural and or functional abnormalities consistent with the presence of LV diastolic dysfunction, raised LV filling pressure, including raised natriuretic peptides. The relevant structural heart diseases are LV hypertrophy and LA enlargement. We can see them by echo or MRA. But the important thing is to see that left ventricular hypertrophy is present in one form or another in more than half of the patients of HFpEF. Similarly, left atrial enlargement or left atrial volume index, which is high, is present in more than half of the patients of HFpEF. So these two structural abnormalities generally contribute quite a lot. Now, the important things by which we diagnose diastolic heart failure or diastolic dysfunction on echo are this E prime, which we see by the tissue Doppler, more than 7 medial and more than 10 lateral. Now remember, this is the most sensitive parameter, and I'll talk about that in the next slide, why this is the most sensitive parameter. Then the average E by E ratio more than 14, left atrial volume index more than 34, and the peak TR velocity more than 2.8. This is the most specific parameter. And in the next slides, I'll talk about these two things, why these are the most sensitive and most specific parameters. So, most sensitive E prime. Now, this was proved by the Norris study. This study was for the establishment of norms in the chamber quantification 2014 study utilizing about 1,000 patients. And this has shown that for all age groups, E prime is going to be higher than 7 for medial and higher than 10 for lateral, and beyond 60 years it may be touching less than 7. Similarly, E by E prime for all age groups, this is going to be less than 15. So this has turned out to be most sensitive parameter, and we know that for all grades of diastolic dysfunction, for all forms of myopathies, E prime is going to be reduced because this is independent of the preload conditions, whereas the pulse wave Doppler findings of E wave may vary with the preload disturbances. So this is the most sensitive parameter, and some of the authorities, including the Mayo Clinic authorities, do say that if you have structural heart disease and only this parameter abnormal, one can diagnose diastolic dysfunction or HFpEF. Similarly, the TR velocity, which I say is the most specific parameter. And why this is so, again from the same Norris study, this has been found that TR velocity more than 2.8 is present in just a fraction of people, 0.3%. Whereas 99.7% of people would have a TR velocity which is less than 2.8. So if you have that, this is the most specific parameter. Problem with this parameter is that as we see that application of all the echo parameters, majority of them are feasible 100% of the times, but the TR velocity is about 70% of the times. The reason is shown in two studies, one European, one American, that TR velocity can be seen only in 40 to 60% of people. So getting a good TR velocity is a frequent problem because this is either absent or not optimal. So we have to use off-axis views. Outside Pakistan, people do use contrast to get that as well. One other thing which I have found very useful is an right ventricular outflow tract acceleration time. So if you have a right ventricular outflow tract acceleration time less than 105, that becomes a surrogate marker for a TR velocity of more than 2.8. So one can use that as well. So for assessment of diastolic function, we have three basic algorithms. One is for diagnosis, one is for filling pressure, and one is for MAC. This basic algorithm we have to look for all the four things: E prime, average E by E, TR velocity, and left atrial volume index. And if majority is normal, one thing is for this we go for E velocity on the pulse wave Doppler. If the E velocity on the pulse wave Doppler is less than 50, then we say that the filling pressure is normal. And if E velocity is taller than the A velocity and E to A ratio is more than 2, we simply say that here the filling pressure is raised. So again, 1/3 the gray area, we have to rely on the E by E velocity, TR velocity, and LA volume index. And here, if majority is abnormal, we say that the filling pressure is normal, otherwise abnormal. And for the gray zones, we can use LA reservoir strain to replace the missing parameter. There are certain caveats that we have to be careful with mitral valve disease, mitral stenosis, mitral processes, bundle branch blocks, pulmonary hypertension. So we have to be careful, atrial fibrillation. And how can we get some information I talk about in the next slides. So again, these are various algorithms. Dr. Shahbaz Qureshi has talked about that, so I would miss that. But this is a kind of a patient where we can have all the parameters present, and this is a grade 1 diastolic dysfunction. The other HFpEF algorithm, where we have major and minor criteria. Major criteria are given 2 points, minor 1 point. These are functional, morphological, or biomarker parameters. And if you have the major functional parameters like E prime and E by E grossly abnormal, then we assign 2 points. So if you have more than 5 points, then we say that this patient have diastolic heart failure. For biomarkers, if there is atrial fibrillation, CKD, obesity, then we have to vary the biomarker ranges accordingly. Diastolic stress test is a very important thing. This can be used for grade 1 diastolic dysfunction with normal filling pressure and disproportionate dyspnea. So here we can use diastolic stress test and see if this is abnormal, then we can tell that this patient has abnormal filling pressure. For diastolic stress test, this kind of fancy machine is probably not available anywhere in Pakistan. Nobody is using that. So to replace that, passive leg raising can be used, and if you elevate both legs passively from perpendicular to 45 degrees for 1 to 2 minutes, this transiently elevates the volume by about 300 ml, and we can have the abnormal thing if there is diastolic heart failure present. So this can be used to replace this fancy kind of thing. Another thing is we have to look for IVC congestion, because a lot of times people are admitted in the ERs where they are short of breath. We diagnose heart failure. And when we look at their echoes, their ejection fraction is generally normal. There are diastolic heart failure parameters, but then we must look for the signs of congestion, and if the IVC is dilated, non-collapsing, these patients do require IV diuresis. Similarly, epicardial fat, which is turning out to be a very new surrogate marker kind of thing, and for diastolic heart failure. And in the STEP-HFpEF study, people are using to measure. Normally, epicardial fat is seen anterior to the right ventricle, only anteriorly echo-free space with a kind of haziness in there. So if you have that present, that is epicardial fat. 5 to 7 millimeter can be normal, and if it is more than that, that contributes to the diastolic heart failure as well. So there are certain difficult situations where it becomes really very challenging to measure the diastolic function, like MAC or mitral annular calcification, atrial fibrillation, and other things. And we can use other parameters like pulmonary vein, Valsalva, strain, and IVRT and timing intervals. We have to be careful with the LA volume only, especially in atrial fibrillation patients, MR, athletes. So we have to be careful about commenting LA volume. And about E by E prime in bundle branch blocks, CRT, severe MRs, AF, we have to be careful. Now, this is the third algorithm for the MAC patients, where people have severe mitral annular calcification. Here it becomes really very, very challenging to talk about the filling pressures. But this third algorithm proposed by the Zogby paper a couple of years back, and again we have to, like if we have E prime which is smaller, then you look for E velocity. If E velocity is less than 50 and you have MAC and E prime is smaller, then the filling pressure is normal. Again, if E velocity is very tall and E prime is small, then filling pressure is again raised with MAC. So the middle kind of patients, we look for the isovolemic relaxation time, like here, put the sample volume over here. And if the IVRT is less than 80, then the filling pressure is raised. So this is the third algorithm. I found it very, very useful because we are seeing a lot of MAC these days. Especially in atrial fibrillation patients, it's very, very challenging. We have to look for the short deceleration time. Some authorities do say that don't comment on the diastolic function in atrial fibrillation patients, but I think we can comment because various studies have proven that these parameters point towards the diastolic dysfunction. Deceleration time less than 160. E by E cutoff. This study shows that in atrial fibrillation patients, we can move it downwards to about 11. TR velocity, if it is increased more than 2.8, E acceleration time, decreased variability in peak velocities. If that is decreased, that points towards raised filling pressure. Isovolemic relaxation time. So by using all these parameters, I think we can comment about the diastolic function abnormality and filling pressure even in AF patients. So this is my last slide. Like the key points for HFpEF patients, ejection fraction obviously is going to be more than 50. Anti-pro-BNP is raised. We have to be careful with the atrial fibrillation, CKD, obesity where it is falsely reduced. E prime is reduced in all forms of myocardial diseases. This is the most sensitive parameter. I have talked about that. And if we have structural heart disease and only this abnormality present, then I think we can safely comment on the diastolic function. Filling pressure, we have to look for the E by E prime, TR velocities. Structural heart disease, we should look for left ventricular mass index, relative wall thickness, Levy, all these things. For difficult situations, we can use pulmonary vein, Valsalva, IVRT and strain, LVH, reduced GLS strain, dilated LA or strain. All these support the diagnosis of HFpEF. And diastolic stress test in selected patients, especially the passive leg raising test, can be used. So if we have a patient with increased E by E prime, LA volume is raised, TR velocity is raised, pro-BNP is raised with dyspnea, with normal left ventricular ejection fraction, think about HFpEF, that this patient has heart failure with preserved ejection fraction. But at the same time, normal BNP and echo do not rule out HFpEF. Use all these algorithms and diastolic stress test in selected patients. Thank you.